Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred to me for an opacified silicone IOL. The patient has an open posterior capsule, and so you're going to see how I'm going to try to very carefully dissect the lens off the capsular bag, remove the lens, do an anterior vitrectomy, and then place a lens into the ciliary sulcus with optic capture and perform a vitrector-assisted peripheral iridectomy. You can tell that the lens is quite opacified. You can see that the surgeon tried to yag the posterior capsule, but realized then that the lens was actually opacified and it wasn't really the PCO. So you can see I've made my incisions. I'm injecting some intracameral lidocaine and then now some dispersive viscoelastic to fill up the chamber and cover the corneal endothelium. This is my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then enter. This is a 25 gauge needle mounted with some viscoat. I'm going under, bevel down. You can see there's kind of a pretty nice solid rhexis rim there. And so when you have a really solid opacified rhexis rim, it's actually pretty strong. I was able to get under it really easily, and I pushed some viscoat and basically visco separating the anterior capsule from the optic. And once I did that, I'm going in with the cannula and I'm going around circumferentially, first getting under the rhexis edge and pushing viscoat very carefully. The areas that are going to be stubborn will be at the optic haptic junction. So you can see here I'm trying to tease off the capsule from the haptic area, and it's a little bit snagged. I have to really gently tease it off, again pushing viscoelastic as I do this. You don't want to be very aggressive with pushing the viscoelastic, so it's really a combination of viscoelastic as well as mechanical separation. So with effort, you see that I was able to create a separation between the capsule as well as the lens optic on the left side. Do the same maneuver on the right side now. This is a cyclodialysis spatula. I'm sweeping side to side as I go. And I'm just trying to get the subincisional area, making sure that I have good separation of the anterior capsule from the lens. So here I'm going to use forceps as well as the Maltzman to tease up that trailing haptic up out of the bag. And once I've done that, I'm holding it with the forceps, and then I'm grabbing another microforceps. We're going to very carefully try to tease that haptic up out of the bag. So you can see I was able to very carefully pop it up. And now using a two-handed technique, I'm just kind of inching my way around and rotating the lens clockwise very carefully to try to tease that leading haptic up. I'm holding it with the right hand and using the forceps to tease that haptic out of the bag. There's a little bit of fibrosis there. Just very carefully teasing it up bluntly by sweeping it. And then once I've done that, grasping it and then lifting it up out of the bag and into the anterior chamber. So once this has been done, I'm using forceps and scissors, lifting the optic up with the scissors with the teeth closed, lifting it up, and then it makes it easier to grasp the optic with the left hand, cutting it completely in half. Continuing to hold the lens with my left hand, going in with forceps in my right hand, pulling the haptic out. And then I forgot that this is a silicone lens, so the non-toothed forceps don't grasp very well. So I have to switch instruments, again with the serrated toothed forceps. This is the IOL cutter, and grasping it and then popping it out. So these silicone lenses are quite slippery, so if it's a smooth surfaced forceps, it doesn't really hold it very well. This serrated tip is much better for this. There's a little bit of vitreous to the wound, and I cut that excess vitreous. This is my anterior vitrectomy. I'm using a infusion cannula through the limbal incision, and then I'm going to use a vitrector through the limbal incision across from it, and I'm performing the vitrectomy. You can see some of the vitreous is white, and that's part of that opacified vitreous that caused the lens to opacify, I believe. So I'm going in higher speed simply because, it's kind of boring to watch vitrectomy. But the point is you need to have a thorough vitrectomy. I'm using my infusion cannula to sweep the incision, making sure all that vitreous to the wound is gone now. And then I'm injecting some cohesive viscoelastic to fill the ciliary sulcus, which is underneath the iris and on top of the anterior capsule. I'm going to widen the incision a little bit. And then this is a 3-piece acrylic lens, which is going to go into the ciliary sulcus. Go in, bevel facing to the left, deliver the leading haptic into the ciliary sulcus just underneath the iris, but on top of the anterior capsule, making sure I'm not underneath the anterior capsule. Delivering the leading haptic. As the optic comes out, you want to rotate your wrist counterclockwise 90 degrees so the optic comes out planar and flat in the proper orientation. And then you want to leave the trailing haptic out facing to the right. And then I'm using the multimeter to dial the trailing haptic into the ciliary sulcus. I went ahead and just reposited the lens in the optic capture configuration. Okay, I tried to lift the iris when I activated irrigation because I didn't want the chamber to suddenly deepen. And I'm now doing the INA of the viscoelastic from within the anterior chamber. You can still see some viscoelastic just underneath the lens. You can see that kind of opaque thing. That's not actually a defect in the lens. That's just a little bit of that viscoelastic that's underneath the lens in the vitreous space. Again, just to reiterate, you have good optic capture configuration when the rexus edge at the optic haptic junction is in a V-shaped configuration. If it's in a V-shaped configuration, that means the rexus is small enough that it is tightly around the optic haptic junction and it causes that tight V-shaped configuration on each side of each haptic. Now I'm injecting something to constrict the pupil, either myocol or myostat, and I increased the speed here because, again, just for the sake of time. And thankfully, it constricted really, really nicely. And now I'm going to go ahead and place a tenon suture through the incision. Again, anytime you're dealing with vitreous, I really don't trust the situation. I've seen too many times where you can have small wisps to the wound, and I do believe sometimes if a patient rubs their eye, you can have the wound gape. So I always like to place the suture whenever I'm doing vitrectomy or complex anterior segment work. And then I'll bury the knot. You can see the pupils come down really, really well. I'm going to go ahead and perform my vitrector assisted peripheral iridectomy. Again, the cut rate is fixed at 30. Aspiration and vacuum are linear controlled. You point the port down on top of the iris. When you increase vacuum, get occlusion, then you activate cut. It's such a slow and methodical cut rate at 30 cuts per minute. And you get a beautifully round and small iridectomy. You can see I'm sitting at the supratemporal location. I always sit in the supratemporal location when I'm doing these cases, just in case I do have to convert to the Yamani or something like that. So this peripheral iridectomy is at the horizontal meridian. So just to make sure that I'm still in the optic capture position, I'm putting the Maltzman in, retracting the iris edge, just making sure that I am still in the optic capture configuration. Again, making sure that the anterior capsule rim, the rhexis edge, is over the optic, creating a V-shaped configuration. So again, this patient had an opacified silicone IOL, performed a very careful dissection of the lens off the capsule using micro instruments, and then once bisecting the lens, performing a careful anterior vitrectomy from a limbal approach rather than pars plana in this situation. Thankfully, it turned out okay. I did not really struggle with dealing with any vitreous. I didn't have to place a trocar or anything like that. Place the lens into the ciliary sulcus with optic capture configuration. And that's part of the reason why I really didn't have to go pars plana, because since I had a nice round rhexis, you can really do all of your maneuvering from the anterior position, because once you put that optic over the rhexis opening and get that optic capture, it really creates a bicameral situation. And then I performed my Vitrector assisted peripheral iridectomy. And again, always whenever you do that optic capture configuration, when you have a tight rhexis, you can pop that optic in, and the rhexis edge should create a nice V-shaped configuration with the apex of the V pointed at the optic haptic junction. So I hope this was helpful to you, and I thank you for your attention.